are you located now?
I'm in Goa.
Wow. तू साला रौनक जिंदगी जी रहा है यार तू यार. हम सब यहाँ पक रहे हैं बम्बई में, दिल्ली में.
You all ditched me, no?
हाँ?
I said you all ditched me.
I know. अरे तेरे को उठा के ले आना पड़ेगा वापस. मेरे घर के नीचे गोल्फ क्लब है.
आता हूँ मैं.
आजा आजा. चला वीरेन,
हाँ
रेडी
जी
है?
सर. हाँ जी सर.
Ready ना?
हाँ हाँ.
We are also ready for you.
हाँ सर रेडी है.
Good.
Sir,
good.
one
sir?
We'll five we will start.
Okay.
और नीचे आने और सर्कल.
चलो वेबिनार के बहाने मिलते हैं हम लोग.
नहीं सर, it was a great idea from your side. Really, I mean.
Very good idea. Very good idea.
So it's a live on YouTube also. This is
so at present this you can see on the YouTube also. It's live streaming going on the YouTube also.
Fantastic. That's great. Yeah, I got that message on my. So that's. Who you?
Sir, I think we can start.
Shall we start?
Yes,
Yeah,
sir.
we should.
Okay, good evening, everybody. We'll be continuing the web series of the ISVIR, a great idea by Dr. Bimal and taken up by the ISVIR Secretariat. I think this is the 4th lecture, and we'll be speaking on endovascular management for acute deep vein thrombosis, and I'll try to keep it as practical as possible. So we all know like DVT presents as a problem. Most of the patients, when they present as an acute DVT, it's basically swelling for them, and then the pain starts. Some of the patients we do lose because of PE, or they may have a shortness of breath. So this is like an acute presentation of DVT, which is basically a short term for patient, or as a referring physician, it's basically a swelling of the leg with pain. And yeah, those who deal with the DVT, the hematology and the other department are definitely worried about PE and death. But when we'll be talking about endovascular management, our focus is to prevent the delayed or the late presentation, which is secondary to the deep vein thrombosis. So most of these patients who are in the younger age group will present as a venous claudication pain, persistent swelling. They may develop post-thrombotic syndrome with a component of venous ulcer, secondary varicosities, and a lot of patients do present with depression, and they'll keep on moving from one doc to different cities in a way to look for a treatment. I mean, Dr. Saab, kuch bhi kar do and get rid of this swelling. So the endovascular management plays very important role to prevent this deep vein thrombosis sequelae. So coming to the facts, we all know that more proximal the DVT, by proximal I mean the involvement of iliacs and the IVC, the greater the problem. So the PTS is phenomena which occurs with the proximal DVT and seen less with the femoral and the popliteal involvement. So, and there are many studies which say like if the patient is treated with just mere anticoagulation, especially those having proximal DVT, will end up with venous insufficiency, ulcers, venous claudication, and the ranges are different in different studies. But we all know like those who have practiced for 10 years and more will definitely come to know that it's not less, and it's close to 40-50% of the patients will present with post-thrombotic syndrome if they are not compliant with medication and stockings. So we all know like that is a recent one which was published and in 2002. I don't know why it's going automatically. So here it says like from 20 to 50% of patients will develop PTS within 1 to 2 years of symptomatic DVT, and severe PTS in up to 10% of the patients. So that's the burden of DVT with late presentation. And we all know, like, once there is a thrombus, so what's the pathophysiology is like the valves, the deep vein valves get destroyed. There is an obstruction, so the venous pressure increases, and all this causes basically venous hypertension that leads to ulcer, secondary varicosities, and claudication pain. So this is what we mean by post-thrombotic syndrome. So young chaps mostly with advanced clinical disease, resistant edema, skin changes, ulceration, venous claudication, varicosities, and then a lot of patients will develop depression, and they keep on visiting docs. So we all know, like, the traditional treatment for acute DVT, whenever a patient comes to a general physician or maybe other guys who are not involved into basically an endovascular management, they start with anticoagulation. So that's the crux of the treatment, and they are happy because most of the patients' swelling resolves over time. And for them, and as well as for the patient, that's what the treatment of DVT is. So rest, elevation, anticoagulation will solve a lot of problem. And especially with no proximal DVT involvement, they settle. But what we are looking at is, as an endovascular specialist, something beyond anticoagulation, how we can help those patients. So definitely looking at these images, this is phlegmasia not responding to anticoagulation, and these are the patients who will be referred to you initially, and then slowly with the awareness in your area, the physicians will start sending in the those cases as well, which needs endovascular management. So look at the leg. So this is basically after a week, 10 days, 15 days of simple anticoagulation who doesn't respond to conservative management, basically. So what would be an indication, ideal indication for endovascular intervention? I would say, like, the simplest answer is when the patient needs the most and the leg swelling which doesn't respond, basically phlegmasia, will be referred to you. So that is the indication. Apart from that, any acute iliofemoral popliteal DVT, basically a proximal DVT with less than 4 weeks ideally, with no contraindication to catheter-directed or pharmacomechanical thrombolysis, qualifies for this treatment. So one thing which is important is talk in detail about the post-thrombotic syndrome, show the images to the patient, family, tell them the sequelae, and then convince them for the endovascular management. Explain the risk, definitely hemorrhage, IVC filter need for angioplasty, stenting, and follow up how they need to come to you, anticoagulation, antiplatelets. No family will accept, remember, losing an individual for a leg swelling. So all the risks need to be explained to them. So this is like a proximal DVT where we see, like, this is DVT extending up into the ilioceval junction, and here the thrombus extends into the IVC. We have seen, all have seen, up to the renal, suprarenal extension. When we are going for an endovascular management, the thing which is very important is we all should be aware of May-Thurner syndrome. So it's basically a component of a lot of things. So there could be compression of the artery over the vein, there could be spurt, there could be fibrosis, congenital narrowing. So there are multiple things in this segment which leads to basically as a provocative to DVT. So I would be speaking on catheter-directed thrombolysis, and latest we have Angiojet, Indigo, and Clear XT. So we do have in India, like, devices, thrombectomy devices, which can be used for instant result. So just an overview, like, before the availability of thrombectomy devices in India, how most of us used to do a catheter-directed thrombolysis was, once a good duplex scan is done, the patient is, counseled for the procedure. This is the protocol which over time I have changed and I follow. So we know that there is a DVT, we do a good Doppler. The DVT is confirmed, everything we know, like the extent, the access, so everything can be planned on Doppler. Nowadays, we go for a CTPA with DVT protocol. Medico-legally, it is really nice to have the demonstration. You need to see the extent of the load into the IVC and maybe the involvement in the lungs. So it's again the operator preference, but this is what we try to do in most of the patients. And then all the labs are performed, a 2D echo, is performed. So this is basics before going for any intervention. Once the family and the patient is ready, we go take the patient to the cath lab or the angio suite. Mostly the puncture, almost like I would say 99.99% popliteal is ready to puncture. You can take an SSV access or direct popliteal depending on the availability of that vein and the swelling. So mostly it's popliteal, but you can go from IJV if required. So usually a puncture under ultrasound guidance, a short vascular sheet. So again, it's operator preference to start with a low profile sheet or directly go with a 6F, because you know that you'll be needing angioplasty and probably stent placement. So it can be upgraded later. Again, I would say almost always a simple catheter and a glide wire combination is sufficient to cross the entire thrombotic vein and park your catheter into the IVC. Once you are there, you can just inject a little bit of contrast to demonstrate, and then straight away you can go with a multi-hole catheter. Again, different catheters are available in the country. So you have a Cook catheter, you have a Crick McNamara, and then Merit used to have now, I don't know whether they are available with that. So these were the catheters. So you go with the multi-hole catheter, and then you start your lytics. Again, we will be discussing with the panelists, like there are different choices, but usually RTPA or a urokinase is usually preferred by the most of the operators. I go with RTPA. So once the thrombolysis is started, we check regularly with the fibrinogen. You can do your routine CBC and RFT monitoring. Next day, patient is taken back for a check venogram. And then at that stage, the clot is, a lot of clot is lysed. If it is within 2 weeks, you can aspirate the residual. Then the underlying stenosis can be demonstrated. So you go for angioplasty, and then if required, a stenting. So if a good inflow outflow is restored, all you need is to remove everything at this stage. Or if there is some, even after balloon angioplasty or stenting, if you see like there is some residual thrombus here and there, then the overnight 10 to 12 hours thrombolysis with a low dose can be performed. And next day, the catheters can be removed. So usually for simple catheter-directed thrombolysis, filter is not required, even if the thrombus is extending into the IVC. But again, it's a debatable topic which can be discussed after the end of the talk. Coming to the pharmacomechanical thrombolysis, again, the protocol remains the same. The advantage of pharmacomechanical or thrombectomy is like the results are quick, can be performed in patients who are basically they have a contraindication for long thrombolysis. So it's a quick go, quick out. The dose of the thrombolytics required is less, and the result which can be achieved over 2 days or 3 days can be achieved immediately on the table, or maybe just after angioplasty, you may need a lysis for few hours. Here again, post pharmacomechanical thrombolysis, the rest of the things remain the same. So you need a balloon, stent may be required. One thing which is important with the pharmacomechanical thrombolysis is if the thrombus is extending into the iliocaval junction, or it's kind of free-floating thrombus into the IVC, then need for IVC filter becomes important, because you will be basically showering the thrombus load into the pulmonary circulation with the mechanical devices. So definitely the advantage is quick, instant, and can be performed in high-risk patients for thrombolysis. So a quick overview on need for, or the indications for IVC filter. I think we can take a call on case-by-case basis, depending on the extent, nature of the thrombus, patient's reserve, whether he already have P or not, and whether you're doing simple catheter-directed thrombolysis versus pharmacomechanical. Nothing is wrong in being safe if the operator feels comfortable with the IVC filter and thrombolysis or thrombectomy. It's fair enough. Family profile is definitely important. That plays a very important role. If even after counseling a patient, if he feels like he doesn't want to take any single chance for the thrombus to migrate, and definitely finances in our country play an important role for taking. So looking at these images, if you see the thrombus load, the iliacs are involved, the iliocaval junction and the renal lever. So in this situation, I would be happy placing a suprarenal IVC filter for sure. If here even you can see the filter is placed above and then a pharmacomechanical thrombolysis is performed. This is a big chunk of thrombus load in the IVC. So there are certain situations in which you have to go with the IVC filter. That is important. Here now, one thing which is important is now we do have IVC filters available with a longer shaft length. So you need not to take any separate access for that. With the same access, you can complete the entire procedure. This is the filter available from Argonne Medical, and the shaft length is, I think, 100. So you can place, so here you can see this video. So it can be placed, and the advantage is it can be placed over the wire. So you can place the suprarenal IVC filter from your popliteal access. So coming to our procedure, so a patient presents with swelling not responding to conservative anticoagulation. So all you do is take a popliteal artery vein access, go inside with your combination of your favorite wire and catheter, park it into the IVC, take a venogram, demonstrate the extent, and then you go with accordingly whether you're going with a catheter-directed thrombolysis or a pharmacomechanical thrombolysis. So that's the access, the catheter inside. And if you have an angiojet, what you do is, it's a great device. So you go over the 035 wire. Here you can see the video. It has a great jet. And this is an 8 French Zelante catheter. So it macerates the thrombus and aspirates. It's basically, in the next slide, I would be showing the advantage of it. So it's basically an 8 French over-the-wire device. The advantage is rotational thrombectomy can be performed. So it can be rotated almost 320 degrees. So that the entire, you can clean the circumference of the vein. It has two modes, the pulse spray mode and the thrombectomy mode. So in the pulse spray mode, you can spray it, the thrombus with the jet and the lytics inside. And in the thrombectomy mode, it aspirates. 2 or 3 things which are important while using angiojet is watch for hemoglobinuria and bradycardia. Hemoglobinuria is basically because of the mechanical disruption. Bradycardia, there are hypotheses like adenosine and bradykinin are released, which causes bradycardia. So you should have anesthesia backup preferable while doing angiojet, because a lot of young patients get panicked while doing angiojet. Catheterization and good IV hydration is important. Otherwise, the case reports are there for acute kidney injury as well. And limit your activation time at each pulse to like 5 seconds, 7 seconds. Don't go at like running the device. It causes a lot of trouble. So this is for angiojet. Then you have another device which is basically a catheter, reinforced catheter from Penumbra. It's Indigo Cat 8 basically. All you have to do is suck the thrombus. It works well. You should be aware of 2 or 3 things. So again, it can go over the wire. It comes with a separator which has an olive tip, but the cost is really an issue. So most of the time I use it without the basically separator, or you can use snare or any other wire, but usually not required. So take a roadmap and then you can go fix it against the thrombus, and the pump is great with a great vacuum and can be used. So these are the 2 good devices available for pharmacomechanical thrombolysis. So 2 or 3 things which are important is start suction when the catheter tip is against the thrombus burden. There's a small little button, you can on it but by sliding it. And stop as soon as you see a flow, great flow start from the catheter, because you can lose a lot of blood. So as I told, like it comes with a separator which is separate, and it's equal the cost of the catheter. So it's not that easy to be used all the time. And you go with an extra torque catheter which can be torqued against the wall. So there, it's one comes with a less torque and the other one is like a more angled one. So go with the more angled one. Now, again, a controversial topic which we can discuss with the panelists who are available throughout the country. So it's a debatable topic whether we stay with angioplasty or we need to stent. In my practice, I would say like good 70 to 80% of the patients with underlying stenosis or the May-Thurner syndrome, spur, you can call it anything, which can be demonstrated post thrombolysis or thrombectomy needs stenting. So I would go somewhere close to 70 to 80% of the patient. Stenting requires detailed counseling with the patient and the family because they may need well antiplatelets. There is need, they need to know about the what is neointimal hyperplasia or stent restenosis, how the follow-up should be performed. So before stenting, we need to really counsel the patients. Try to avoid stent if you can in adolescents and females desiring future pregnancy because of the drug which they will be taking. So that is one challenging area where a stent, whether to put or not, is again a difficult situation. So now we do have a dedicated venous stents available, and they are preferred over the prior generation stents. And again, we'll be discussing in detail about the anticoagulation and antiplatelet protocol. There are no consensus, but I think the practice do vary, and we'll be learning from each other. So just, yeah.
The direction of we can't see your face. I think the direction of your camera is changed.
So what shall I do for that?
I think just change the direction of the view, possibly your laptop or slightly.
No, even I am not able to see myself. Okay.
Yeah.
I don't know what happened.
Invisible.
You are invisible, like.
Oh.
Okay. Okay, I think let's proceed.
Okay. Okay, fine. So now coming to the, let's go back. Okay. So coming to the stent part, I'll be showing few slides. Like to begin with, initially, the most preferred stents were like wall stents and the Luminex, which were like bigger size. And a lot of guys started stenting in this fashion. So we used to extend the stent into the IVC and jail the contralateral iliac veins. This is how we used to do initially. And because the dedicated venous stents were not available, the other thing was a lot of thrombus at the iliocaval junction extending into the IVC. So the worry was if you don't cover that region, there could be a possibility like we may reocclude. So this was one way of stenting. Still, it is done if there is a lesion extending into iliocaval and needs to be done. So the downside of this was we can see like in at least 5 to 10% of the patient due to basically the jailing of the contralateral iliac vein, the thrombosis and is noted. So this is the downside of jailing the contralateral iliac vein. But the numbers are not huge. Many studies have been done, and they have come to a conclusion like somewhere between 5 to 10% of the patients develop contralateral DVT secondary to jailing of the iliac vein. There was one study I was looking at yesterday. So they say like they have compared the wall stent to basically Cook Z stent. So we know that as the spaces between the struts are bigger in the Z stent, the thrombosis of the contralateral iliac vein was much less compared to wall stent, because wall stent is basically a closed cell type, and so they don't recommend placing a wall stent when you are jailing the contralateral. So there are few studies, and if possible, I definitely agree that we should not jail. So we can go with the latest stents or maybe the conventional ones and try, if the iliocaval junction is not bad, we can stent with this technique. But sometimes the problem is, you look at this line, what happens is the inner side goes little higher when you're placing the stent on the ipsilateral side. And sometimes if you go a little higher, it can act like basically a stab to the contralateral wall. So you have to be very precise. The other disadvantage is sometimes the lesion, or you're not able to clear the thrombus in the iliocaval junction, then you miss this part because of the straight basically end of the stent. So now we do have an oblique stent. I would just go over quickly. So what they say is like because of this segment of the common iliac vein, it is could be a lesion, could be a compression. So you need a stent with a more radial force. So what they have done is they have made a stent which is called as obliquus, because it's an oblique in shape, and it has 3 components. So this part has the highest radial force, and then there is more flexible, and in the last or the proximal part for the anchor, they have a little more radial strength. So this is one which is available if we are not jailing the other side, and if the lesion is not really extending into the iliocaval junction. It's a nice one. So this is like an image where you have pre-thrombolysis image, post-thrombolysis, everything is fine. You've done a plasty, and then you see there is a residual lesion, well demonstrated on venogram, you can do an ISVIR. So once this run is done, you are for sure, you know that the stent is required. And here you can see an oblique stent. The advantage is the inner end is basically being oblique. So you just keep it at the bifurcation, and the opposite end is basically longer. So it goes a little bit into the IVC. It's again, the challenge is you can see there's two markers in between. So you have to basically align it so that they are in one line, which is not that easy. So that's the only basically learning curve. Otherwise, it's a good stent. And here again, you can pull it little back and exactly place at the confluence. So this is what we have in our country now. So coming to the follow-ups, we know like once the thrombolysis is done, the swelling disappears very quickly within like hours, and the patient gets rid of his pain or her pain. And yeah, putting a DVT pump is not a bad idea if patient is with you for a day or so, and then he can be discharged on basically compression stockings. So I would say, to summarize, our understanding of the venous disease definitely has evolved over time. We can achieve technically excellent results as an endovascular specialist for our patients, but we need to choose correct patients. The proximal DVT should be basically preferred for endovascular intervention. Thrombus age less than 14 days, excellent results are there. Patient with low bleeding risk, and definitely effective clearing of the clot, addressing the underlying venous stenosis, and adopting a rigorous post-procedure anticoagulation and ultrasound surveillance should be in our protocol. So that's about the DVT with acute DVT with management. I'll be just showing few pictures like the setup in the OT. So usually we go with a prone position. It's easy to puncture popliteal. And next day when you bring the patient back, you can keep him or her in supine position with the leg little flexed, and everything can be performed in supine position so that patient is comfortable. This is one way of doing it. And would be showing just a case. Sometimes what happens is with experience, you start doing less basically venograms. So you know your Doppler findings. If you have a CT, you know the extent. So you puncture, you pass your wire with a catheter or sometimes just a Terumo wire, and then it's stuck. So usually this is the point of basically May-Thurner. So I would say like 95-98% of the time wire with the catheter crosses. But with your experience, if it is not crossing, wait for a minute. You don't have a CT scan. This was a case in which we had not done a CT scan. So the wire was not growing. And don't try to really poke and cause some disruption or basically rupture of the vein, because you know you'll be doing a thrombolysis. No thrombectomy devices were available at that time. So stop, just do venogram, see where you are. And then this was the picture basically. So there was basically a blunt end, and then the internal iliac was there. So we punctured the contralateral side. We saw like why it's not going from this side. We tried everything, 014, 018, everything was tried. So you tried to come from the contralateral side. That didn't work. So the thing is, just wait and watch and start your thrombolysis from wherever your catheter stops. And if you see the next day, the vein starts visualizing. So don't be aggressive on day one. If you're not able to cross, just wait and watch, start your lytics and bring back. And most of the time you'll be able to see. There was just one case in which I could not cross, and then we demonstrated it was basically, I don't know, congenital absence of common iliac vein. There was no way we could enter even on follow-up scans. So we just did a lysis, putting the catheter into internal. So the internal was draining through the contralateral internal. So here the plasty was done, and then whatever, if you need to stent, you stent it. So this is one thing which is important. If the wire does not cross, don't push it. Give some time, bring the patient back. These are like few cases in which now we have 3 cases. These were the basically a non-retrievable filters. You will encounter such cases with acute DVT. So a filter is placed mostly by whatever we got was from the cardiology side. So basically young chap with non-retrievable filter, and then patient stops his anticoagulation, he is thrombophiliac, and then develops an acute DVT of both lower limbs. So you can do basically 2 catheter from each groin or popliteal region thrombolysis, or you can go with thrombectomy devices. And after clearing a lot of thrombus, still it's basically acute on chronic. That's what I think. Slowly the neointimal hyperplasia starts and all that. So these are few tough ones. And I mean, 3 cases, which I have done was even after clearing with a thrombectomy device, it was not going away. So I taking an advantage of trapez filter. 2 balloon mounted 10 millimeter stents were placed with a nice flow. And none of the patients have come back, but the follow-up is not more than 3 years. So this is one thing important. Coming to role of IVIRs, I would try to finish it very fast. So same pattern, you do thrombolysis or thrombectomy. Once the results are clear, in some situations, you may land up like whether we should go for a stent or not. So you have done a balloon. Now the flow has restored. There are some filling defects. That's fine. Now going to the next image, look at here. So we know that there is still the pressure. So it doesn't look that great. So there was a debate on the table. The patient was just 15 years old. The imaging wise, it doesn't look that bad, although there are some collaterals. We have plastered with 14, 16, so leave it. Now look at the IVIS. IVIS gives us the answer. So we have done a contralateral run to demonstrate, and then the IVIS, just a quick run through the IVIS. So it's a pullback basically run. Come on. Okay. So you're pulling back the IVIS catheter from the IVC. IVC is well open. We're going down, pulling down. So as we approach the iliocaval junction and reach the common iliac, you can see that the catheter is inside that. So look at the narrow caliber. So here it's basically the flat CIV. Here you can see how flattened it is. So on venogram, it's basically what we see is 2D structure. So sometimes if it's a flattened kind of thing, if you look at AP, just one view, it would look like it's a good diameter, but here you can see how narrowed the vein is around the catheter. Although the patient was too young, so we just did a aggressive plasty and he went back with the just after ballooning. So that's it. I think I have already told about the Cat 8. The just one advantage is it goes over the wire. So initial pass you can do over the wire. Once a flow is restored, the catheter easily passes without the wire, and then you can rotate it across the wall and try to basically aspirate the thrombus. So again, this was a case with a simple indigo catheter. Okay. So these are the questions I think we all need to discuss. It's a request to all the panelists. Indications for CDT PMT for each of us. Choice of lytics, we can discuss on choice of multi-hole catheter, use of IVC filter, when, and only angioplasty versus stenting. What is the protocol for antiplatelets and anticoagulation, and role of IVIS? Thank you. Can you guys hear?
Yeah,
Yes, yes.
Yes, we can.
Where my video has gone.
I think we should take all these topics one by one.
Yeah.
So coming to the indication of CDT and PMT.
It had something to do with your screen. Now we can see you well.
No, now we can see. Now we can see that way.
So whole of the he has become, because of the infection of the corona, he has become a hollow man. So that the
I don't know what. Now I just did some restart of the video. Yeah.
Anyway.
Yeah. So we can start with basically. Do we have questions?
Yeah, there are.
We do.
There are 4 questions.
So somebody has written, if we do not have angiojet or other high-tech PMT catheter, can we use just balloon to macerate the catheter? If yes, what size balloon? And secondly, if we find any lesion near iliocaval junction, can we do a kissing stent procedure in this to prevent JD? No. It's a question for Dr. Vimal, because before PMT and all that, he has the vast experience with this aspiration.
Couple of things. Number one, this is a thrombus, so balloon will not help so much. So one definite thing is no balloon. If you don't have these advanced devices, the least you can do is take these large diameter aspiration guide catheters, 8 French or something like that. In fact, sometimes I have preserved the IVC sheath, the sheath with which you deploy the IVC filter, those are sometimes bigger ones also. The latest ones are all 6 French, but the older ones were big, or even the sheath which you use for snaring the filter out, those are 10 French and 11 French. You can use that. And then you aspirate and do thrombolysis and whatever. I would only use balloon if there is an underlying obstruction. This is one thing which I would add to Viru's talk, that if you have aspirating, you are doing thrombolysis and still there is some segment which is not opening up well, go there and balloon dilate.
Right.
Once you dilate it, then the passage is open. There should be through and through flow for your thrombolytic agent to work. So that's the only time that I will do it. Kissing stent, I don't do in the IVC iliac region, venous side. So initially we used to gel it, as Viru has shown those cases. And nowadays we are using these special obliquous stents and things like that, special venous stents in these cases.
Right.
So the first question,
yeah,
the indication for CDT and PMT, in other words, indication of interventional treatment of a patient with DVT. I think there is some difference in opinion, and even within our country, there is some difference in the practice. For example, I know for a fact that Girish and Vimal has a more aggressive approach than, for example, what we have. But I think there isn't a consensus here, and it is a question about what is your usual practice. For example, I think I heard you say, I missed the first 2 slides, Viru, when I joined.
right.
But in my own practice, I do give them, if they come in within 4 or 5 days, I give them at least 48 hours of conservative treatment. If on heparin or anticoagulation, the limb girth and the circumference is reducing and the pain, we do a strict VAS, VAS code. If the VAS code is reducing, we do not go for interventional treatment. We continue to treat conservatively. I think age and everything else do come into this. Patient's expectations and what the patient wants all comes into this. But it would be nice to see a view of what, how aggressive you are. I know that there are some centers where every DVT gets a intervention. So what is sorry, Vimal.
Yeah, so in my case, I do all the DVTs. Up to even 21 days, I would go and do a thromboaspiration lysis. So earlier the better is my philosophy. If they have come in 4, 5, 6, 10 hours, 1 day, 2 day, go in and do it as early as possible. Iliofemoral segment should be cleared up.
And you will do that in every case?
In every case.
So I think there should be some clinical indications, definite clinical indications, and the guidelines that this patient has presented with these symptoms, these much are the symptoms, then only we should proceed. Like, so what are the basic guidelines and what are the literature says? Dr. Pradeep.
First of all,
I think, can you hear me first?
Yep.
Yes, Pradeep. Hi.
Yeah, I think first of all, congratulations, Viru. It was a really very comprehensive talk and, very nicely presented, very, very informative. I think right at the beginning, you have very clearly said the discussion with the family is very relevant. I think what Dr. Arun is asking is the guidelines and the protocols. I think the recent trials which have been done, they have clearly not been much helpful, in the sense that evidence-wise, there is no strong evidence either way whether we should do it or whether we should not do it. The only thing which it says is, as you rightly said at the beginning, if there is no contraindication to do thrombolysis or pharmacomechanical thrombectomy, then you basically offer the patient the treatment, and that too for a iliofemoral segment, not for femoropopliteal on its own. So as far as the evidence is concerned, unfortunately, we have not reached that point. The only evidence is if it is iliofemoral and if there is no contraindication for thrombolysis or pharmacomechanical thrombectomy, then you basically discuss and offer the treatment to the patient. Now, all this was in the West, where the information, guidelines, and the questioning or the probity, everything is there. But as Shubroy was pointing, we all do things differently. And obviously the experience comes in picture. And as Dr. Vimal clearly said, his experience for over so many years has been treat most of the patients. Now I'll just run through our own experience of what we have faced of doing and not doing. And recently a very youngish, 28-year-old chap with everything normal, creatinine wise and heart function, no contraindication, what looked like a May Turner, very minimal thrombosis of iliofemoral segment, leg was quite significant, and he came within a week. So we discussed with him, a very well-educated man. He was in UK for some years. So he has read about it, he has spoke to them, and we offered to him. And we did all background things, what is necessary, we did it. We did an angiojet. And in retrospect, if I think, the thrombus load was not that much, but definitely there was what looked like a May-Turner syndrome. So we did it, we cleared it, but unfortunately what transpired was he withheld some of the history of his, diabetes, uncontrolled hypertension, chap ended up with AKI, and he's still on dialysis. Another patient just 4 weeks ago, IVC and iliac veins involvement, significant, all the indications were there. Finances were not an issue. Cardiologist is is a relative in Delhi. So he made all the inquiries. He didn't want to fly, which is never recommended. So we did in him. Excellent result. No need of any stent. IVUS was clear. Absolutely, there was absolutely no need to doubt our final outcome. What we see 4 days down the line, everything got occluded. So,
no, in this case,
so what I'm trying to say here is we have actually not come to a conclusion which cases, suitability wise. I think the key at the very beginning, Shura, you might have missed a couple of slides. At the beginning, what he clearly said was discussion with the family is very relevant. Give them all the choices. And if you have practiced enough for more than 10 years, if you follow them long term, the syndrome of post DVT does happen in a lot of patients with or without these aggressive treatments. And if you give them good anticoagulation, good compression, the results are satisfactory given the Indian circumstances, finances, and all those things. I think only time will tell where we reach. I think that is where I want to stop, and others can please add in.
I think Pradeep, just very quickly, sorry, very quickly. I think we can debate this till the cows come home.
That's
because
right, yeah.
in every international national meeting, when this discussion goes up, there are two poles of thought, and that is why ATTRACT is often quoted, and ATTRACT did not show a clear direction, and ATTRACT has its lot of criticisms as well. So let us not go into this. I think the bottom line is, clearly Vimal has been doing this brilliantly for a long period of time. I mean, we have been seeing his pictures for a long time. I am at the completely opposite end of the spectrum. I treat conservatively most of the time, intervene very few cases. There is probably a happy in between, and I think every individual in discussion with the family and the financial circumstances must come to an individual decision per patient. I think that is the bottom line.
So, bro, I'll tell you what, how I look at it. If there is a mechanical obstruction,
yes,
due to May Turner and secondary thrombosis or any malignant mass or anything like that, there is a mechanical obstruction.
You must treat it.
Yes. If it's
I think that is
patient, yeah. If there is a prothrombotic condition, we know that the repeat chance of getting a DVT is again very high in these patients. So these patients will require a long-term anticoagulation. So some of these factors have to be looked at. If you have placed an IVC filter, see that you talk to the patient. That is where Viru's discussion comes in, that they are compliant to come back and remove the filter. Otherwise, filter will create a problem for you. So some of these things are very important. While discussing with the patient, you have to tell them that anticoagulation should go on for nothing less than a year and a half. Even if there is no coagulopathy. This is what we look at. So, stent, reocclusions are very high, venous side. We have realized you put 16, 18, whatever, the reocclusion rates are quite high in them.
So Vimal, can we summarize for our youngsters that if on the CT venogram or on clinical suspicion of the patient's age, presentation, etc., an obstructive pathology is more likely, then you would
Yes.
rather go intervene, including going and POBA plus minus
Yes.
putting a stent.
Stent,
So
yes.
I think, could that be a consensus, guys?
1 minute, Subro, can you hear me?
Yes,
sir.
yes, Girish.
See, the point is, when a patient lands up with DVT because of, say, May Turner, whatever said and done, it is very difficult for you to demonstrate that there is a May Turner or not. Because
Girish, तेरा
always-
voice बहुत soft है, Girish. Either
no,
come
I-
close to the computer.
I am,
No, just
Yeah,
no,
yeah.
I'm with the mouthpiece. I don't
just
know.
pick
Yeah,
up the
it's good.
mouthpiece.
Okay, 1 minute.
Yeah, now it's sounding. Okay.
Rajesh is not identifiable, by the way. Rajesh, nobody can identify Rajesh, by the way.
So my basic question is, do we anyhow will treat the femoropopliteal disease or
क्या हुआ?
so
Hey, I see my favorite person.
any situation we proceed with the femoropopliteal disease, or okay, we agree that ilioceval disease is definitely possibly most of the time will go for treatment. But what about femoropopliteal? In any case, should there are indications for treating
Okay.
this?
Arun, we have to
Usually not.
understand. We have to understand the physiology and the flow dynamics in the lower limb venous system. If you have an iliopopliteal, femoropopliteal segment, even if it is occluded, okay, the collateral from the superficial veins will take over. And this superficial vein will drain into the common femoral vein and up into the iliac veins and then IVC. Till the time your iliac and IVC is open, this drainage is good enough with a compression dressing to manage the post-thrombotic syndrome. So in the femoral veins, popliteal veins, I never do it. I don't know if there are some cases where you would do it. I've not experienced anything where it is indicated. But yeah, anyone else who has done this, Rajesh, Subra, Girish?
Sir, can you repeat your comment regarding ilio IVC junction? I just missed it.
Ilio IVC junction.
Yeah.
So that segment, if there is a stenotic segment, commonest is a May-Turner syndrome. Okay. In those segments, just doing balloon dilatation does not help. You have to have some mechanical device with a good radial force to keep the right iliac artery away from the iliac vein. So I always like to put a stent there. I don't know how other people look at it.
I recently had a case in which there was some clot, residual clot on the ilio IVC junction on the right side. It was a lady. Rest all the clot cleared. So I was skeptical whether to put a stent, balloon, or just anticoagulation for prolonged period. On right side, it was there.
So you should remember, even on the right side, you can get May-Turner.
Okay.
I know it is not very close to the IVC iliac junction. It may be a little lower down, but you can get right-sided May-Turner also.
Okay.
Vimal, can you hear me now?
Yeah, Girish.
Better?
Yeah.
It's unclear.
Acha, so what I was saying was, when Subro was saying that we do a CT or imaging to make out whether there is a May-Turner or not, when there is thrombosis, it's very difficult to identify that. So unless you do a thrombolysis, you won't be able, or mechanical thrombectomy, you won't know. The second thing is that basically,
So the point,
if you go by evidence, this is level 2B evidence. So level 2B evidence cannot justify us doing it. But over the period of time, we've seen how it works. So for one, what I do is I would select my patients that if they are, say, about 45 and below, I would take them up. If they are 45 and above, then I may try to do it conservatively. Of course, if I'm suspecting May-Turner irrespective, I would do it. But if the patient is above 60, so definitely I will not. I would just put them on anticoagulation and wait and watch. That is the way I'm following it as of now. But I get very aggressive if the patient is younger.
Yeah, agreed.
I think
So
let's
I
go
think
to
go. Yeah, there are very interesting questions. So we'll take our other questions. So Dr. Gaurav Sharma has what time duration CDT can be done means presentation of more than 14 days. So I think Dr. Vimal has told like he is okay with 21 days. I have done till 4 weeks as well. So but we need to remember the earlier the better it is. And again, the patient and the family has to be counseled for that. So yeah, everybody agrees?
Yeah.
One question.
Yeah.
Sorry, one question, guys.
Yeah.
Just very quickly, apart from the acute DVT, there is another setting of patients. It's not very common, but they come in 2 years after an episode of DVT with a hugely post-thrombotic swollen limb, sometimes with ulcers, and an atretic, almost occluded long segment stenotic or atretic iliac vein. What is your approach in those patients?
Okay. I mean, let everybody participate. Yeah.
Yeah, Doctor, we can unmute Dr. Rajesh. I think he's not unmuted.
Yeah. Now I'm.
Yeah.
Yeah, Rajesh. अभी क्या किया है तू?
बस ऐसा थोड़ा सा change, sir.
Yeah, very good.
I strongly feel that those ectatic veins, if we can access them nicely, we should do a simple balloon angioplasties. No stenting for sure, but balloon angioplasty and a long-term anticoagulation. Most of these patients have post-thrombotic syndromes with non-healing ulcers. They do respond very well. Thereafter, those ulcers would require a grade 3 compression stockings. And I believe just a plain balloon angioplasty is enough. I've seen few presentations where echos have been used in such systems, but as echos is not available in India, I don't know, we can't use it, so we can't share the images of echos. But echos is something which is very promising in chronic thrombotic veins with a wonderful results after angioplasty.
I think Rajesh has summarized that beautifully. I think Rajesh has summarized it beautifully. Thank you.
I think what is most important is that we should have a good inflow. Unless the inflow is good, it is going to be a waste of time. That means to say, if your common femoral vein is good, there is a good diameter of the common femoral vein, and you have an ectatic or a very narrowed iliac vein, then is a good idea what Rajesh has said. But if the quality of the femoral veins are not good, whatever you do is not going to help.
You're more than just the common femoral. Girish, more than the common femoral, your profunda femoral or the deep femoral vein should be draining very well. There should be a good inflow from there.
Yeah, profunda is the key.
Yeah.
Now there are really practical questions I think we should answer.
Yes.
Yeah, so one by one, there is one question from Dr. Abhishek. When should we ask the patients to put compression stockings, even in acute setting or after a few days? Anybody can take that.
Can I answer it?
Yeah.
Yeah, I think in acute setting, most of the times what happens is you start them with the crepe bandage or the high grip, which is now available, so that the acute edema settles down. And after a couple of weeks, what happens is it comes to a size where the appropriate size stocking can be used. So the compression starts on the day one. There is no doubt about it, unless there are some, the blebs or skin ulcers but don't give stockings from day one because it's of no use in the sense the size will change. So start with the, the crepe bandage.
So quick answer is like, ASAP. So the answer is ASAP. So another question is, do you do fibrinogen level monitoring while on thrombolysis? So how many of us follow this? Yeah. So yes,
we always
we all do
follow.
that.
Yeah.
Yeah.
It's expensive, but unfortunately, legally, we can't stand if there is a problem.
Yeah, so we all do that. Yeah. So there's one question: can we avoid stenting in May Thurner in patients who have good collaterals and CDT PMT? So I think I would go ahead and stent it, as Dr. Bimal told, like 80% plus. I would stent it. Yeah.
Sorry,
So
Arun?
when to look for fibrinogen level?
Huh?
First day, second day, third day. When
No. So as the patient is on thrombolysis, you will have to monitor fibrinogen level at least 8 hourly or 12 hourly, how you do in your hospital, but it has to be at least within 12 hours. So we usually 8 to 12 hours. It has to be.
Yeah.
So if
How
the
does it
fibrinogen
help?
goes,
How does it help?
so you can titrate your dose accordingly, especially in the basically how we do it is, especially in the arterial side, it becomes more important. So as the fibrinogen level drops, you know that the chance of bleeding increases. So you can titrate your dose accordingly. So as the fibrinogen approaches on the lower side, so for example, you send the sample at X time and the fibrinogen level comes 150 maybe. But you know, like the sample has been sent to lab, the report will come after 3 hours, 4 hours. So by the time the report comes, the fibrinogen level would be 100. So somewhere when the fibrinogen drops between 100 to 150, I usually half my dose. So what we are doing, and if it is less than 100, 180 or 80, I would stop it for basically an hour or so.
Yeah,
So
so
that
it
is
helps
very
you to
important
predict
in arterial.
Yeah, it helps you to predict the bleeding conditions.
Yeah, it's very important.
So both APTT and fibrinogen levels.
Yeah, yes. Again, a good question came here. So as Dr. Vimal told, so how many of us give heparin basically, and what dose?
Yes.
Yeah, along with thrombolysis, because APTT is usually required for that. Again, that's a big debatable question. So I will take the questions from the audience first. There are a lot of,
exactly.
Yeah. So the question was, can we rely on good collaterals? I think answer is no. If it needs to be stented, I think it needs to be stented. Otherwise, it will occlude. Another one is after stent placement.
I think Viren, you can actually add here.
Yeah.
Viren, you can say that when you are actually dealing with the stenting of the iliac veins, presence of actually collaterals is an indication for stenting.
Yeah.
So that's actually one of the indications for stenting for the youngsters who are
100%.
So you make sure that the collaterals disappear. That is what is your aim.
Yes.
So regarding the use of heparin in thrombolysis, now coming from a school where thrombolysis was used mainly in the arterial tree before the treatments of DVT came by, and I still use the very conventional way of thrombolysis that I was taught as a very young age, which is a combination of TPA at a fixed dose to start with, and heparin with a target APTT ratio between 2 and 3. I use the same for the venous system. I am not sure of any evidence or literature. I'm happy to be educated on it. If there is any literature specifically for thrombolysis within the venous system, but my practice is to give heparin as well as TPA.
Okay, so I'll give